to the PAD podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter, and Instagram with the handle bar at Shafir Ahmad 4109. And please feel free to share these chunks of knowledge. Thank you. Today, the topic of a discussion of the podcast is multiple sclerosis. Now, multiple sclerosis is an autoimmune demyelinating disorder characterized by distinct episodes of neurological deficits separated in time, attributable to white matter lesions that are separated in space. So, what do we mean by separated in time and separated in space? So, let us try to little bit understand these concepts. So, attacks or exacerbation of multiple sclerosis are characterized by symptoms that reflect central nervous system involvement. So, the symptomatic episodes are separated in time and space. It means that episodes can occur months or year apart. So it is not like a continuous episodes. It can occur for months, and then after several months or in a year the next episode will occur. So it means that separated in time, and by separated in space we means that it affects different anatomic locations, not like the same locations. When you are just seeing the MRI, so we'll see multiple lesions on multiple areas. So that's the term separated in time and space means. Now, it is the most common of the demyelinating disorders, having a prevalence of approximately 1 per 1,000 persons in most of the United States and Europe. Now, the disease may become clinically apparent at any age, although onset in childhood or after age 50 is relatively rare. Women are affected twice as often as men, and mostly the women are involved. And in most patients with multiple sclerosis, the illness shows relapsing and remitting episodes of the neurological impairment. And the frequency of the relapses tends to decrease during the course of illness, but a steady neurological deterioration is characteristic in a subset of patients. So we will today understand the pathological component of the multiple sclerosis, and our podcast will highlight related to all those things like pathogenesis and morphology. So if we can see the pathogenesis, so it is believed that multiple sclerosis, like other autoimmune disease, is caused by a combination of environmental and genetic factors that result in a loss of tolerance to self proteins. So the self protein in the case of multiple sclerosis will be the myelin antigens. So myelin antigens will be the protein in which this antigens through which the body will lose the tolerance to the myelin antigens, and hence it will cause havoc to this nervous system, and it will cause the classical symptoms of the multiple sclerosis. So the nature of the initiating agent often suggested to be an infectious agent, although it is remained unclear so far that whether which viruses are usually involved in this pathogenesis, but usually it is just suspected that it might be an infectious agent which might have triggered this the onset of this disease. Now, many lines of evidence indicate a significant contribution of genetic factors to the risk of developing multiple sclerosis. So, the disease risk is 15-fold higher when the disease is present in a first degree relative, and the concordance rate for the monozygotic twins is approximately 25%, with a much lower rate for dizygotic twins. So, concordance rate means that in genetics, the concordance rate or concordance is the probability that a pair of individuals will both have a certain characteristic phenotypic trait, given that one pair has the characteristic. So for example, if one twin is having one specific phenotype, so other twin will also have that specific phenotype, so we calculate that probability through the concordance rate. So the concordance rate for multiple sclerosis, in which both of the twins, monozygotic twins, will develop multiple sclerosis, so it's 25%, and for dizygotic twins it is much lower. A significant fraction of the genetic risk for multiple sclerosis is attributable to HLA-DR variants, and specifically the DR2 allele being the one that most significantly increases the risk for developing multiple sclerosis. And many other genetic polymorphisms have been linked to the disease by certain studies like genome-wide association studies. Two that have received considerable interest are polymorphism in the genes encoding receptors for the cytokines IL-2 and IL-7. So interleukin 2 and interleukin 7 receptors are involved in it, which are known to control the activation and regulation of T cell mediated immune responses. So usually T cell mediated immune response are involved in pathogenesis of multiple sclerosis. So in view of the prominence of chronic inflammatory cells within and around multiple sclerosis plaques, as well as the genetic evidence, immune mediated myelin destruction is thought to have a central role in the multiple sclerosis. And what we have discussed in the start, that it was the loss of the tolerance specifically to the self antigens like myelin antigens. So evidence from human studies as well as from experimental allergic encephalomyelitis, an animal model of multiple sclerosis in which demyelination and inflammation occur after immunization with myelin proteins, or certain peptides from myelin proteins. So after immunization with myelin proteins or certain peptides from the myelin protein has suggested that a range of immune cells contribute to lesion development in multiple sclerosis. And a central role for CD4 positive T cells has been suggested with an increase in T helper 17 and T helper CD4 positive cells, thought to be a critical component of the injury to the myelin. And there is also evidence for important contribution from CD8 positive T cells as well as B cells. And while multiple sclerosis is characterized by the presence of demyelination out of proportion to the axonal loss. So demyelination, like the myelin sheet, is disrupted much more than the true axonal loss. So some injury to the axon will occur, but demyelination is the predominant injury in the multiple sclerosis. And when myelin sheath is disturbed, so what will happen, that nerve conduction signal will not pass in a speedy way as when myelin is intact. So toxic effects of lymphocytes, macrophages, and their secreted molecules have been implicated in initiating the process of axonal injury, and sometimes in the severe form of the diseases, it can lead towards the neuronal death, and you will find symptoms related to the axonal injuries in contrast to only injuries related to the demyelination. So what are plaques? The second question arises, that what are basically that classical plaques of the multiple sclerosis. So now we will discuss the morphology. That multiple sclerosis is primarily a white matter disease with affected areas showing multiple well circumscribed, slightly depressed, glassy appearing gray tan irregularly shaped lesion termed as plaques. Now the plaques commonly arise near the ventricles, and they also are frequent in the optic nerves and chiasm, brainstem, ascending and descending fiber tracts, spinal cord, and cerebellum. And the lesions have sharply defined borders at the microscopic level. So what will happen in the active plaque? That there is an evidence of ongoing myelin breakdown with abundant macrophages containing myelin debris. So there are macrophages which is eating away this myelin debris, and then lymphocytes are also present, mostly as perivascular cuffs, and small active lesions often are centered on a small veins, And exons, just like discussed previously, are relatively preserved but may be reduced in number. So the plaques, what are the plaques that myelin is breaking down with the help of macrophages, and when we are seeing under the microscope there are also lymphocytes making a curve around the vein and mostly near the ventricles. So there are four active classes of the active plaque known as type 1 class, type 2, type 3 and type 4. So the recognized macroscopic patterns, the type 1 which has macrophage infiltrates with the sharp margins, and then the type 2 which is similar to type 1 but also shows complement deposition, suggesting an antibody mediated component. So what is happening in the type 2? In the type 2 you will also find the complement deposition, but in type 1 there will be only macrophages. Then with the type 3 active plaque with less well-defined borders and oligodendrocytes apoptosis. So oligodendrocytes which are surrounding the nerve sheets, they will start dying away in the type 3 active plaque. And then in the type 4 with non-apoptotic oligodendrocytic loss, and when plaques become inactive, the inflammation mostly disappears, leaving behind little to no myelin, and instead astrocytic proliferation and gliosis are prominent. So clinically what will happen, the course of multiple sclerosis is variable, but commonly there are multiple relapses followed by episodes of remission. Typically recovery during remission is not complete, and as a consequence over time there is usually a gradual, often stepwise accumulation of neurological deficits. And when you see on the imaging on radiology, it is demonstrated that there are often more lesions in the brain of the patients with multiple sclerosis than might be expected from only the clinical examinations. And that's why we have used the term that it's separated in space and time. So there will be a lot of lesions, not in the same anatomical locations, but on different locations on the MRI. And the lesions can come and go much more often than were previously suspected. Changes in cognitive functions can be present but are often much milder than the other deficits. And in any individual patient, it is hard to predict that when the next relapse will occur, and most current treatments which are intended to control the immune response aim at decreasing the rate and severity of relapses rather than recovering lost function. And the characteristic finding on the CSF in patients with multiple sclerosis will show mildly elevated protein levels with an increased proportion of immunoglobulin in 1/3 of cases. There is also moderate pleocytosis. And when immunoglobulin is examined further, so you will see that classical oligoclonal bands in multiple sclerosis, and these antibodies are directed against a variety of antigenic targets and can be used as markers of disease activity. So B cells are clearly involved in the pathogenesis of multiple sclerosis. The contribution of these characteristic antibodies to the disease process is still unknown. And this concludes our podcast related to multiple sclerosis for today. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.